And so what I'll try to do with you is go over, again, a little bit of repetition, go over the criteria that you've heard about, go over a little bit of the history, and then go on what are the therapeutic possibilities. So you heard today that we evolved from a situation where there are, in fact, or there were multiple diseases with different phenotypes, and that somehow in the 1970s, Moll and Wright recognized them to have common features, clinical features, radiographic features, and in the end also it was turned out that there were common genetic features, with the most striking one, of course, HLA-B27. So these different diseases somehow got together, linked in a concept which was at that time termed seronegative polyarthritis. And you heard about different classification criteria, the first one being the real strict criteria to identify patients with classic ankylosing spondylitis, and then the efforts that were made to sort out a group which had spondyloarthritis features, which could be either peripheral or axial, where you had the Amor criteria, which are actually performing quite well, but as Philip Mees told you, are impossible to do in daily practice because you have to remind what are the numbers, what score do I get for each point, you have to add them. So that's actually not very feasible. And the second set of criteria was the ESSG, the European Spondyloarthritis Study Group criteria, which are actually, from a conceptual point of view, quite easy to understand. You either start with the back pain or with the peripheral arthritis, which is the same as in the ASAS criteria, but which were thought to be not very specific. And then that changed in the beginning of 2000 with two things. First of all, there was the advent of biological treatments, the TNF blocking agents, which were quite expensive therapies, which were thought to that we had to reserve them somehow for some specific patients, and we could not let them loose on the whole field of spondyloarthritis. So we were a little bit worried about the non-specificity of some of these criteria. And then the other thing which happened in the 2000 and more was the advent, as you heard, of MRI. So this gave rise to the criteria. You saw this slide, and this is actually a slide combining both the axial and the peripheral criteria. But the bottom line of this is that you start with some typical feature, and then clinically you would then put together the different features that are typical for spondyloarthritis, and in your mind make a diagnosis. So if you now ask me how do they perform as classification criteria, that's fine, because actually you know the specificity and the sensitivity, and classification actually is just a question of yes, you fulfill them, or no, you don't fulfill them. And it allows you then to identify a group which may be helpful in following in the long term, or for unleashing a certain therapy on that group, because you know that some therapies might work better in axial disease compared to some other treatments that might be better working in peripheral disease. But of course, the idea was not to design classification criteria for the purpose of classification. The actual idea was that we are stuck in daily practice as clinicians with the fact that patients do not stumble into your consultation from one day to the other with the diagnosis of ankylosing spondylitis, and that we recognized that there was something before that which was characterized by back pain and which needed to have some other features. And the classification criteria from a diagnostic point of view, or the items which are in there, actually help you to distinguish either by virtue of the MRI or by adding a sort of pattern recognition of different clinical features, that you can distinguish patients in an earlier phase, which then would potentially prevent this, the long-term consequences of not having this chronic inflammatory condition controlled. And so actually we moved, and there is different Venn diagrams which are available. You saw a few of them. This is another one which actually tells you that spondyloarthritis is a sort of an overlapping large group. Within this group, you have a number of diseases which are our old diseases like ankylosing spondylitis, inflammatory bowel disease, psoriatic disease to some extent, and again, that can be discussed, reactive arthritis, which could be evolved, but the large ball of spondyloarthritis, which we used to term undifferentiated spondyloarthritis, is now comprised into this new concept. And as told, you can have patients who have predominant axial disease, and that will be the focus of the therapeutic options we have in there, but you have also patients who have predominantly peripheral disease. So again, you use classification criteria for classification. That's easy. If you use them for diagnostic purposes, that's a different story, where you put more weight onto some of the criteria, where you can, for example, think that some of the criteria may be somehow redundant. For example, personally, I would think that if you're B27 positive, that probably a family history of spondyloarthritis is a little bit difficult and may not be counted in the same way as, say, for example, psoriasis or uveitis. So now we've made the diagnosis, so what about therapy? And I think the first item we should never forget, because in these focuses with ACR and FDA and all these regulatory maze problems, there is always the problem that, yes, but what about these very expensive therapies? I think the first thing we should recognize is that these patients need, first of all, we need to recognize the disease, and secondly, we need to educate these patients. The first step is that to tell them you have a chronic disease. It's not a nice thing to say to a patient, but the other option, if you don't recognize this type of disease, is that a lot of these patients will end up in the orthopedic surgeon department, will have their discs taken out by orthopedic surgeon, and in the end, they only had an inflammatory condition which needed to be recognized and needs to be educated about. So I think this is still the mainstay, especially if you treat very early, if you recognize very early, educate the patient. But of course, if there is a consistent problem of back pain, then you need to treat it with medication. And the first thing that then comes to our mind is treatment with non-steroidals. And there is a bulk of evidence to suggest that. And I'm just going to show you a few things which you probably all know very well. This is on the left-hand side of the slide. You see quite old data, which actually tells you that if you give a non-steroidal to a patient with ankylosing spondylitis, he will normally respond quite well. Whereas if you give it to someone with mechanical back pain, the response is definitely lower, which is, by the way, one of the criteria which helps you distinguish these inflammatory conditions. But you can also see it in placebo-controlled trial, which is on the right side of the slide, which is a typical study where you have patients with a disease, you withdraw them from the NSAID which they are on, and then you put them in a placebo-controlled trial, and clearly you can see that the drug is working. Now, we know from the guidelines that you should probably try a few of these agents before you start with other treatments. And then it is put in the guidelines that this could be done in a rather quick way. You should only treat them for about a month or a few weeks. Now, the point I would like to make with the next slide is that probably in patients with early disease, we might have to wait a little bit longer. This is a trial actually comparing a group in blue, which only receives a non-steroidal anti-inflammatory drug, whereas the red bars represent patients that are being treated with an anti-TNF agent, with on top of that a non-steroidal anti-inflammatory drug. And what you can see in this slide is, although the combination with the biologic clearly outperforms the non-steroidal alone, you can see that at a 28-week time point, there is a significant proportion of patients which goes actually into clinical remission if you treat them consistently and early. On top of that, we know that if you treat patients continuously, this is also data which was also already referred to by Chris Richlin, if you treat patients continuously with non-steroidal anti-inflammatory drugs, you can see that there is a difference with regard to structural progression. Over here, this is the group which takes the non-steroidal in a continuous way, and there's approximately 80% of the patients who do not progress in a 2-year time period, whereas there is only 60% and 40% is having some progression if you only treat them intermittently. Then the question pops up, do we really have to treat now all our patients with non-steroidals full dose for the rest of their lives? And there are a couple of answers we can give. And this is a reanalysis recently done from the same trial where they looked again at these patients that were treated on demand and the patients that were treated in a continuous way. And what you can see over here is that this effect of the non-steroidal given continuously only plays a major role in the patients who have a high CRP, so who have an objective measurement of inflammation, whereas in the patients with low CRP, this actually is not giving any difference. So that's a first clue. If you have objective parameters of inflammation, that's probably the best group where you can unleash the chronic non-steroidal therapy. Do you have to give a full dose? I didn't put the slide in here, but you already saw the data from the German spondyloarthritis cohort, where again they could confirm these results, that in patients who have a higher risk of getting radiological progression, namely the ones with a raised CRP and the ones which have actually indeed already baseline syndesmophytes, if they were given high-dose nonsteroidals, again, they showed that there was less progression, and high-dose nonsteroidals was defined in this study as having an NSAID index of 50% or more. This actually means that in your daily practice, you would have to calculate more or less what is the total maximum dose of a nonsteroidal, and there are tables which can tell you that. Let's say you would have a patient on diclofenac, the total maximum dose would be considered 150 milligram. So actually, if you go over these data, it would mean that if you would have a patient taking 75 milligram of diclofenac daily, or taking 150 milligram every other day, or something in that type of combination, you would probably have a certain protection against structural damage. That's the situation we have right now. If we're looking at actual disease, which is over here now, and we failed nonsteroidals, then the problem is that we don't actually have any data to suggest to us that there are other classical disease-modifying agents which can help us. So we end up pretty soon with TNF-blocking agents. And we have now a wealth of TNF-blocking agents. We have the receptor with the Fc fragment. You all know this. We have different monoclonal antibodies. And we have an FAB fragment conjugated to polyethylene glycol, which is certolizumab over here. And overall, these drugs in ankylosing spondylitis perform quite the same. This is the ASAS40 response, which is a clinically meaningful response, which distinguishes between active drug and placebo. And across the board, about 40–45% of patients will experience, when they have ankylosing spondylitis, such a response regardless of the anti-TNF agent. And if you look at the new kid on the block, which is certolizumab, and this is the rapid actual SPA trial looking at the subgroup of patients that classified or having ankylosing spondylitis, you can see very similar ASAS40 responses, and for that matter, also similar ASAS20 and partial remission scores in these trials compared to the other anti-TNF agents. So is there other things that might help us distinguish? And then there's, of course, the extra-articular manifestations, which help us in one way to distinguish the patients. If you have a patient with psoriasis, your probability of dealing with this type of disease is higher. If you have a patient who had uveitis, the probability of making a diagnosis is also, again, higher. So does this play a role in our therapeutic considerations? Well, this is a slide which is not a head-to-head comparison, but here we are comparing different responses in patients with psoriasis, and look at the gray bars in first, which represents the ACR20 responses in psoriatic arthritis pivotal trials. And you can see that the gray bars overall show you an ACR20 response of about 60%, a little bit less, a little bit more. If you now look at PASI 75, which is a very major skin response, and you look at the purple bars which are actually representing the PASI 75 scores in the trials which were done in patients with psoriatic arthritis, but looking at the ones that had also skin involvement, you can see that there is a difference with somehow a higher response with monoclonal antibodies compared to, I must grant that, the usual dose of etanercept, which is 50 milligram weekly. If you go to higher doses, you do see some dose response. But even if you go to the PASI 75 in psoriasis, pure skin dermatology studies, which was only done for the 3 first agents over here in the red bars, where you can see there is somehow a difference. And we see that same sort of situation when we look at uveitis, which is another extra-articular manifestation, where again you can see if you don't treat patients, you see a number of flares of uveitis, whereas both of the TNF agents that were studied here give you a diminishment of the number of uveitis flares with a non-significant but numerically better effect with the monoclonal antibodies. And other studies have really shown this, that there seems to be a little bit of difference. But of course, the most striking difference between the anti-TNF agents is when you look at Crohn's disease patients, where indeed it's the monoclonal antibodies like infliximab, adalimumab, who have been approved for the treatment of Crohn's disease, whereas etanercept clearly has not been. And now you can argue, is that important? Well, we think, especially coming from the department where I work from and where we've had a long history in Ghent of sticking a colonoscope in every patient that would come to the department with something which would smell like spondyloarthritis. Well, we've recently redone this exercise, and this is very recent data, looking now at patients with early disease, which was about 2 years of disease on average, with peripheral SPA according to ASA's criteria, non-radiographic axial SPA, so the pre-form, and then ankylosing spondylitis. And if we performed colonoscopy in these patients who had no symptoms whatsoever with regard to their gut, we could find that in up to 33–35% of patients with ankylosing spondylitis and a little bit less with non-radiographic, we could find chronic lesions in the gut, chronic lesions which were, one, independent from the fact that they were taking non-steroidal, so the intake of non-steroids was not playing a role, and these lesions actually resemble very much what you see in Crohn's disease. Another thing which made us really convinced that this thing is real is when we looked at these patients, and we looked at the ones with normal gut histology, with acute gut histology, but especially at the ones who had chronic inflammation in their gut, and we linked that to the severity of the sacroiliitis, we could find a correlation there too. So this, to me, points towards the thing that you should look probably for one way or another, an objectivation of the complaint. The back pain is there, so you can use the MRI, but clearly other things like a raised CRP, or in this case, the prevalence of chronic gut lesions also points towards a more objective measurement of the disease. So if you want to go now beyond TNF, suppose you have a patient who doesn't respond to TNF or who is intolerant to a TNF blocking agent, what are your options at that moment? Well, I'm sorry to say that there is not a lot which is currently available. Over here, this is again not a head-to-head comparison, but I try to summarize in one slide what's in the literature. You have the 4 anti-TNF agents which are approved for ankylosing spondylitis. You have over here the new drug within the family of the TNF blocking agents, and in this rapid axial SPA population, there was the possibility that some of these patients, albeit it was a very small group, could have been pre-treated already with another biological, and so this gives us an indication that switching indeed may make some sense. On the other hand, we have very good and nicely conducted studies with IL-6 blocking agents, of which you see 2 over here, sarilumab and tocilizumab, which didn't work at all in ankylosing spondylitis. And we have not so good studies where actually it was really an open label sort of tryout, sort of proof of concept, but where actually there was never a real signal that something worked in these patients, especially when you were going to look at patients that had failed previous treatment over here, rituximab in patients that previously failed an anti-TNF, or abatacept that previously failed an anti-TNF. There was no signal that these drugs were of any help. Strengthening somehow that indeed rheumatoid arthritis, where all these drugs work, and spondyloarthritis are different diseases. So is this a situation where you now should all go depressed back home? I don't think so, because there is something on the horizon which seems at least promising. We know from psoriasis that IL-17 is a crucial cytokine, and this is a study from the German group. This is Heiner Appel's publication, looking at IL-17 T cells in the zygoapophyseal facet joints of patients with AS and comparing to osteoarthritis, where actually there was clearly an overrepresentation of these cells, and this fits, until now, all the data we have quite nicely with preliminary phase 2 studies. This is from Dominique Baeten, who published this recently, where you can see that indeed if you give an anti-IL-17 antibody, you get an ASAS20 response, which goes up to the height of about 60%, which is what you come to expect with a TNF blocking agent also. So somehow a response which is within the same ballpark, which seems promising, but awaits further confirmation in phase 3 studies, which we'll probably hear of in the next years. This is another drug within the same ballpark. This is targeting IL-12, IL-23. Again, ustekinumab is an approved drug for the treatment of psoriasis, works very well. And this was an open label proof of concept study, but in contrast to the studies with rituximab and with abatacept, which didn't show any definite response, you can see in this open label study, which is presented at this year's ACR meeting, and just I encourage you to go and see the poster. ACE has 20 responses, albeit in an open label study, 75%, ACE has 40, 65%, ACE has partial remission, 30%. So at least something for which you can use as a basis to go further on. So ustekinumab seems, again, a promising target to be further investigated. If you talk about small molecules, the situation is not so very clear at this moment. We have one study with apremilast, which is a phosphodiesterase 4 inhibitor, which has very robust data in psoriatic arthritis, and actually can be considered probably as a very good DMARD in psoriatic arthritis. But there is one study where it was tried out in a spondylitis patient population, which actually didn't show a statistically significant difference, but nevertheless it's been taken into a larger trial, which will provide a definite answer, hopefully, whether this drug is really helpful. Tofacitinib entering dose-ranging studies. So who should we treat and when should we treat patients? Now this would be very fancy and nice to show you. This is again a poster from our department which will be presented tomorrow. And this is not a standard scintigraphy, but is actually a scintigraphy with certolizumab labeled with technetium. So what you see over here is a picture of two spondyloarthritis patients, albeit that this one is a psoriatic patient, who has a clear-cut dactylitis, and where you can see that the picture shows uptake not only in the first phase of the disease, but also 5 hours later and 22 hours later, there is still an uptake, which made us think that probably we are looking at a real effect and not just at some sort of a specific inflammatory thing. So what we could do in this study is really demonstrate the presence of the cytokine, in this case TNF, by giving a scintigraphy with an anti-TNF agent labeled. And over here you see a similar picture, but this time from a patient with an Achilles tendon, a severe Achilles tendon problem, where again you can see that there is uptake of the biological over there. And so the proof will be, of course, can we use this to predict a response? We don't know yet, and that has to be proven in the future. But this is, of course, would be a very fancy technique. We don't have that at this moment, and so we're stuck for the moment with rather crude use of different clinical features. And let me just show you a few examples. This is a grid which is based on phase 3 studies with golimumab and infliximab. And let's say we take a patient who is young, who has a little bit of inflammation, is B27 positive, and has a BAS-Phe which is not that elevated, so the function is still quite good. Well, that patient in this grid would have a 43% chance of going into partial remission if you would add an anti-TNF agent. If you would take, on the other hand, somebody like me, which means middle-aged guy who is B27 negative, has a normal CRP, but just received from the tax department his letter saying that he had to pay taxes, which makes your BAS-Phe go up because you don't feel all that well if you receive that tax letter, then that type of patient would actually only have a 4% chance of getting a response if you would treat with an anti-TNF agent. So these simple combination of clinical features can help us to distinguish. And so if we think about therapy, and if we take this whole grid, because it's a very complicated grid, we should probably appreciate that there are things like symptom duration. You see over here younger age, higher age, things like an elevated CRP, things like B27, positive MRI, which was not in here, and then certainly specific comorbidities like psoriasis, Crohn's disease, ulcerative colitis, uveitis, which drive our decision to treat. And so if we think about the different items in SPA, we use them differentially for classification, for diagnosis, but also for therapy. And so the final question that leaves me is, if we should now look at symptom duration, and if we realize that the earlier you treat, the better you're off, what are the data to support that indeed if you treat in an earlier phase that you are better off? And this whole thing probably started some years ago with the InflixiSpine study, which was published by Nick Barkham from Leeds, where actually he took out a population which had very early AS, and that was probably a combination of real AS patients, according to modified New York criteria, and patients with non-radiographic disease, but who were B27 positive, had a positive MRI, had very short symptom duration. On average, this was only about 1.5 years. And if he treated these patients with placebo versus with infliximab, he got approximately 60% of these patients into partial remission, which is clearly higher than what you see in AS population. And the interesting thing, which probably triggered all this talk about early treatment is that if he followed these patients at 5 years, and of course this is very incomplete data, but what he could see is that unfortunately half of this original patient group was not followed anymore, but of the half that was still followed, 5 were in still remission and without having any treatment. So the question arises now, if we would treat early, does that provide us with a window of opportunity to treat patients earlier and to stop the treatment once they reach remission? And in order to look at that sort of thing, we had to do some trials, and so this is ABILITY-1 showing you the primary endpoint, which is the ASAS40, in the group that got the adalimumab versus placebo, which is a response comparable to what you see in ankylosing spondylitis. But if you looked at patients that had objective inflammation, which was defined by either positive MRI or an abnormal CRP, that goes up. Whereas if you see patients who don't have objective inflammation, there clearly it doesn't make sense to treat them. If you would have more objective inflammation, if you would take MRI and an abnormal CRP, the possibility of getting a response would even go higher. And this is then the rapid axial SPA trial. Very shortly, the total patient group, the AS group, and the patients that had non-radiographic disease. What you can take home from this slide is, first of all, the BASDAI is similar, so the burden of disease, as Philip Mees already mentioned to you, is similar. There is somewhat lower BAS-Phi and lower BAS-ME, which is not surprising because you're probably looking at an earlier stage, but for the rest, this is very comparable. And if you look at the response to an anti-TNF agent, the total group, the AS subgroup, and the non-radiographic axial SPA, I think you can appreciate that there is no real difference, strengthening, in fact, the concept that there is something there like axial spondyloarthritis. And this is the final edition, which was published this year, and there's also data at this meeting. This is looking at etanercept patients treated in a non-radiographic stage. And again, you can see there is a response, which is an ASAS40 clinically significant response. And again, if you select out patients, in this case with a raised CRP, you get a better response. So in summary, I tried to put it in one slide, and it's sort of a personal feeling, what we have right now. If we look at monoclonal antibodies, they seem to work all along the board. In naive ankylosing spondylitis patients, in patients that have failed TNF blockers previously, so switching, in patients with non-radiographic disease, and they work fine for extra-articular manifestations. Etanercept does the same, but probably not to the same extent with the extra-articular manifestations, certainly not with regard to the gut. Certolizumab works well across the board. Ustekinumab, we're looking at the first data now that there may be a signal with AS patients, but it needs to be confirmed in placebo-controlled studies. And we know that it works very well in the skin, and there is indeed this interesting data from Sherlock that in the antithesis, IL-23 may play an important role. Secukinumab is under investigation with regard to AS patients, also with regard to psoriatic arthritis patients, but it's quite a difficult situation. When you look at extra-articular manifestations, it works very nicely for the skin, seems to be even better to some extent than anti-TNF agents, but on the other hand, it seems to be able to provoke flares, and it's definitely not effective in Crohn's disease. So where do we have to put that? That the future will have to tell us. Then I told you about the, let's say, rheumatoid arthritis biologics which do not work, and we have to await further confirmation of small molecules. So with that, I'll end this presentation, and I think we'll go to the questions.